I guess we could start. It's 5:31. I think a few more
Yep.
people will trickle in. So we're lucky to be joined by Dr. Tyler Koski today. Who'll be talking about adult spinal deformity. He's one of the foremost experts in this topic and does many cases annually. He did his training here at Northwestern and has been here since on faculty. So without further ado, you can go ahead and get started.
Cool. I'm gonna figure out if I can share my screen the right way and try and make this go. My computer's not cooperating, sorry. There we go. All right, you got me there? Everything good?
Yep, looks good.
All right, requisite disclosures. Some screw stuff in there. I'll show you lots of screws today, but you won't tell which ones they are, so it won't matter, I think. So this is my kind of whirlwind, hit a lot of topics, throw a lot of stuff at you, adult deformity talk. So some of you probably heard it before. It's, objectives are to kind of just introduce some topics. There's some real basics in there that it's always good to go over some basics. Just throwing some of the jargon out at you that you will hear when you talk about deformity, so you know how it applies and can start to develop a framework to think about it. So when we're talking about adult deformity, and just an aside, like the SRS has something that they don't want to call it deformity anymore because that offends people, and so we'll see what we do. But we're going to be the scoliosis football team or something. So that we're talking scoliosis, which for adults, oftentimes that's a de novo degenerative curvature, but adult idiopathic is also common. Essentially, that's teenager scoliosis that grew up and now generally gets some degenerative change on top of it and starts to become symptomatic, or iatrogenic, which is we screwed somebody up. Kyphosis, bending forward, and sagittal imbalance. So a flat back deformity doesn't have to be a kyphosis. It can be a relative kyphosis, but you could just have a loss of lumbar lordosis or a inadequate lumbar lordosis and develop a sagittal plane imbalance as well, which we see a lot of that in the post-operative multiple operated patients. That's a increasingly common thing we see. So scoliosis, whether you want to be a deformity surgeon or not, you're going to see it. Even somebody that comes in with a single level lumbar radiculopathy, and if you get an x-ray, you're going to find scoliosis more commonly than you'd ever think, especially if the patient's over 70, you're likely to see a scoliosis if you get an AP x-ray on them. Whether it's relevant or not to what you do, right, matters a lot on which level you're talking about and what you're planning to do to them. So getting a standing x-ray is a part of my workup for every patient that I see. So just whatever type of spine surgery you're practicing, it's something you need to be aware of and be factoring into your plans. So I always start these deformity talks with kind of what I think about in terms of steps to correct a deformity. And I kind of try and hit on a few of these as we go through. So it starts with the evaluation, sort of identifying the deformity. What is it? Where is it? How do you radiographically assess it? What are you going to do if a surgery is appropriate, which oftentimes it isn't, but when it is, how are you going to do that? And then what are you going to do in surgery to get that correction that you want? And that often comes down to essentially what you do is you're going to have to fixate the spine. You need to get some anchors into the bone. Usually that's screws, but it can be hooks, wires, tethers, all sorts of other things. And then you're going to release the spine, whether it's just soft tissue release, bony release, ligamentous disc. And then you're going to try and move it into the position you want it to. So you're going to put some rods in and bring those screws, bringing that bone with it to those rods to get that appropriate correction. And then you got to get fusion, of course. So let's talk about some of the measurements. When we talk about scoliosis, that's a coronal or frontal plane deformity. It is a rotational deformity, so it is not a 2D issue. It is a twisting of the spine, but we measure that on an AP x-ray. We measure something called the Cobb angle. And just remember, when you're doing a Cobb angle, you're measuring the top of the top to bottom of the bottom. So you're going to try and get the whole curve, but you want to do the superior end plate of the upper vertebra to the inferior end plate of the bottom vertebra. If you're doing the sacrum, obviously it's a little different scenario, but generally that's what you try and do. Sometimes it's hard to see where the end vertebra really is. This sort of is out of this old SDSG alignment and measurement manual, where if you look at a disc, if it's wide on one side and compared to the other, you can tell that is the convexity of a curve. And you can see as it starts to tilt back the other way up here, you're getting to the other curve. So you can identify end vertebrae that way. Oftentimes this disc in between becomes parallel. So you get a parallel disc where you can tell where your transition zone is pretty nicely. This was hard when you had to use wax pens on actual x-ray, and where you drew your line was where you drew your line, and everybody's going to judge you based on how well you did. Now that we have packs and measurement tools digitally, I draw the line on the top and the bottom, and I will oftentimes drag it a level up or down just to see if it looks like it's more or less. It's an easy way to check that. And you are always trying to measure the biggest curve that you can, right? You're trying to measure the full curve. So the levels that are the most tilted in are the ones that you want to measure. And then when you report that, so if I was talking about this curve, I would say it's a T12 to L4, X degree angle. When you really report that, that's the way generally to do that. And when we talk about intra-observer variability, so same person measuring the same film at different times, it's plus or minus 3 degrees. So there's quite a bit of margin of error in how we measure that. And I tell patients when they get really worked up about is it 1 or 2 degrees off, we are measuring a 3-dimensional structure on a 2-dimensional film. And it's not nice, smooth end plates like you see in this cartoon here, right? It is a rotated structure. You're trying to figure out where that end plate is. And that's where dragging that line around sometimes can be helpful for you. So spinal balance, when we talk about the coronal plane, it's essentially a plumb line from C7, midpoint of the sacrum. What's the distance? That's how much you are off coronally, relatively straightforward. Sagittal alignment, we talk about thoracic and kyphosis, lumbar lordosis. We used to always talk about these numbers. We know that is highly variable, and it's varies patient to patient. So 40 to 60 degrees doesn't mean, oh, if you're in the 40 to 60 degree range, you're normal. If you need 70, 40 is really abnormal for you, even though it would be sort of in what is the average range, but it's not a normal range. And the thoracolumbar junction, generally think about it being relatively neutral. So T10 to L2, we don't have much of either. It's a transition zone. So we started talking about, this is like early when I was training, like sagittal balance is all about a C7 plumb line. Drawn from the centroid of C7, drop straight down, measure the posterior superior aspect of the sacrum. It is a relatively easy thing to measure on x-ray. It's a quick and dirty. How far is it? More than 4 centimeters is technically abnormal. But again, we vary that quite a bit. That's a good test of where the person is standing in space on that x-ray, but it doesn't take any compensatory measures into account. And that's why all these other measurements have come along. So pelvic parameters are something that everybody should know. Whether you're an orthopedic surgeon, neurosurgeon, you are not exempt from knowing this. This is on the neurosurgery boards now. So it's something that everybody needs to know. Pelvic incidence essentially is the shape of your pelvis to the shape of your spine. How is your sacrum aligned within to your hip joints? And just a quick, easy way to think about it is if you draw a line on an end plate of S1, from the midpoint, you draw perpendicular. So this is a 90-degree angle there. And then you measure to the centroid of the femoral heads. If the x-ray is nice and overlapped, then it's just one spot. If there's 2 femoral heads, you see, you draw midpoint to midpoint and take the center of that line. This angle is a fixed angle because it's essentially the only thing that moves in there is your SI joints, which don't move very much. So whether you're standing up, lying down, that value should be the same. So we say that's a fixed unit. We also measure, so that's essentially how tilted your sacrum is and how much lordosis you're going to need to stand up with that sacrum. So high pelvic incidence needs more lumbar lordosis. Low pelvic incidence needs lower lumbar lordosis. The components of that are something called pelvic tilt and sacral slope. So pelvic tilt is easy. It's that same point that we had to the femoral heads. Instead of to the 90 degrees, it's to the vertical. So we are now measuring a point on the body to the outside world. So that's why this value can change with position. So you're measuring to a straight up and down. So if it's a standing x-ray, which it needs to be a standing x-ray because you're measuring the vertical, if they move around in space, that value will go up or down. Sacral slope is essentially that same line that we had here to the horizontal. And so the higher the sacral slope, the more lumbar lordosis. Conceptually, sacral slope is a little bit easier, thinking about how tilted the sacrum is. But when it comes to surgical planning, far less useful. We sort of ignore it for the most part. Cranial center of mass is something that we published a decade ago now. That, right, as a neurosurgeon, we sort of said, well, we're forgetting about the head, and I kind of live up here, not at C7. I always thought so. We went through and measured what normative values are for that. I saw Larry Lenke talking about it just last month and talking about how he uses the head measurements now more than anything. So I was happy to see that, but not something you'll generally be tested on, but a useful value to be aware of. They are similar. So the head should be just a little bit in front of the C7. There are values that are angular measurements that are there's many of them. People talk about now. I heard about an L1 pelvic angle the other day. There's a T1 pelvic angle. Essentially, if you do research and you're trying to measure a bunch of films, and you have one brand of X-ray machine and I have another brand of X-ray machine, and people stand at slightly different distances, there's a calibration issue. So I don't know if you saw that first X-ray. There's some weird little measure. There's some weird little bars on one of my X-rays. That was an old-fashioned belt we'd put on patient that allowed calibration for multi-center studies. This tries to get around that. Essentially, it's trying to get a C7 plumb line and a pelvic tilt kind of into one angular measurement. Can be really useful. And if you're doing multi-center studies, an angle is an angle, no matter what the magnification, where distances are different depending on calibration. So that's why we would use something like that. I just don't know what to do with it. I don't know if I know I would need to be less than 14. I don't have a formula in my mind of how I calculate my corrections that way. So I don't really use it as what I do, but it's something that certainly to be aware of, and understanding the concept matters. And you'll hear about some of those angular measurements, and you really just need to know, hey, what's the norm here and what am I shooting for? But again, it's not so straightforward with how you calibrate your correction to match that. Something called the gap score is really interesting, I think. It is essentially trying to figure out the subsets of alignment. So they talk about relative pelvic version, how tilted your pelvis is. Relative lumbar lordosis is what percentage of your lordosis is from L4 to S1 versus the remainder. We all know that 2/3 of the lordosis should be from L4 to S1, but you look at a lot of people that try and correct a deformity, they've got this hyperlordotic L2 to 4 segment in a relatively flat L5 or L4 to S1. That is physiologically abnormal. And people that do mid-lumbar PSOs, which was really popular a decade ago, people that do ACRs, which is still popular now, where they're doing anterior column releases with a lateral and trying to really get lordosis up at L2-3 and L3-4. It's physiologically wrong to have your spine lordotic there. And the gap score tries to factor those things in. And essentially it takes spinal pelvic alignment and again, that lordosis distribution is what I was just talking about actually. And it gives scores to all these factors. Now this is a lot of work to do. I don't know anybody that actually does it in their clinical practice. If they would automate this and just spit out a number, which we will have someday, that might be really helpful. But the moral of the story is, if all of these factors line up and you have a low gap score, your chances of having a mechanical failure of your deformity construct is super low. If you're in the severely disproportioned group, meaning it's all out of whack, your lordosis is in the wrong spot, you don't have enough or you have too much, the mechanical failure rate approaches 100%. And that's either a junctional kyphosis or a rod fracture or something along those lines. So getting it wrong has a definite impact on how well your construct holds up. You know, it falls off a little bit if you're talking about like outcome scores and other things, but it's a cool concept. And what I take away from it is I need to get the lordosis where it's supposed to be and get it in the normal zone. If you do that, you're doing pretty well. So when I think about what are my real goals here, coronal, I'm trying to get them as lined up as I can. Paying attention to pelvic obliquity matters. Sagittal, I want the SVA under 5 centimeters. I want the pelvic incidence to lumbar lordosis under 10 degrees, but I don't want it over. Like some people say somebody has a pelvic incidence of 55. I don't want 65. That's way wrong in my book. I want 48 is what I'm really trying to do. I think a little under correction on that leads to a much more durable construct than overcorrection. I want a pelvic tilt of less than 20 degrees. 15 is considered normal, but we don't want to go quite that aggressive with a correction. And I want 2/3 of the lordosis L4 to S1. I think that matters a lot. And if somebody has questions along the way, I know I'm just sort of breezing through. Stop me anytime. Just speak up. This is pretty casual. So getting away from that was sort of radiographic workup. What is the deformity? How do we measure it? And what are we trying to tell what that deformity is? Getting those patients evaluated and do they need surgery is much harder than the actual correction itself. Like, when do they need something? Why do you do it? And people with scoliosis or kyphosis have back pain. Yes, they do. And they manage it for a really long time. When they start to get
severe, Tyler,
Yeah.
Sorry, buddy. Can I jump in real quick just before we leave the radiographic measurements part of the discussion? Can you just shed some light on, out of all these measures that we look at, what's the sort of clinical correlation on these? Like, which ones probably matter the most, and how strong are those linkages?
Yeah. I mean, I think they all matter to some degree, and especially if you're operating on them, right? If you're not operating on them, it is sagittal plane. So somebody that can't stand up straight in the sagittal plane has the biggest impact on function. There's really good data on that disability. Coronal imbalance, so something that's shifted to the side, unless it gets really significant, is much better tolerated. For me, and I was, kind of working towards it here a little bit, people have back pain and functional issues. They tolerate the back pain with lifestyle modification. They just change the way they do things a little bit. When they start to get a significant sagittal imbalance and can't stand up or walk for very far or very long, meaning they can't stand up to cook a meal without having to sit down several times, they start to have significant disability that they then are considering treatment. That's for the sagittal plane patients. They come in for that. The scoliosis patients that aren't sagittally malaligned, they go for a long time and they deal with that back pain. But when they start getting concavity stenosis or radiculopathy, then they decompensate. So they can put up with it for a long time until they start to get radicular pain on top of it, and then it all sort of starts to snowball on them. So that's
perfect. Thanks for shedding light on that. Yeah, right. Yeah. And in the end, it's just about making sure the symptoms match the radiographic findings, right?
Absolutely. Yeah. There's, it's if you spend even a little time in clinic seeing deformity patients, there are some real patterns that you start to pick up on pretty quickly in terms of what drives people to disability, and you can tell pretty quickly who's going to end up with surgery sooner rather than later, and who you need to spend a long time sort of trying to ride them out. So, all right. So, when we talk about these pre-op patients, so they need a surgery. The surgery is huge. It's really stressful. Can they deal with it medically? Is their bone health good enough? Because if it's not, you're just starting a mess. So bone health has become a huge deal in all the spine world, but especially the deformity world. Do they have the support system? Can they get through this operation? Will they have the support to do it? And I tell people we are the goal of spinal deformity surgery is to allow somebody to stand up and walk for greater distance, greater time with less pain. I tell them that every time. That is the goal. That is how we're going to define success. And the price we're paying is we lose all range of motion generally through that lower thoracic and lumbar spine. That stiffness is guaranteed. The benefit is not, and that's the gamble that we're taking in doing that. So you always have to factor in how that stiffness is going to impact somebody. And a T10 to pelvis is really stiff and alters their life quite a bit. A T2, T3, T4 to pelvis alters it significantly. Those patients generally have a hard time even like wiping their butt. So if you tell somebody, boy, like, yeah, I'm going to make you stand up straight, but you're not going to be able to wipe your butt again. It just sort of sets oh, wow, this is going to be really different and difficult. So that's a big deal if you take them that long segment. So you always have to factor that in. Like, is it really going to be worth it for somebody, especially for young people? So when I operate on adults, surgical patients, it's pain. It is back pain. It can be leg pain. If they start to get a little weakness, even if they're not having a lot of pain, maybe that pushes us, but that's pretty uncommon. And then radiographic progression. So I see people that come in for the scoli checks. We get an x-ray, we measure it. They might progress a little bit. It is pretty rare to see people jumping in like 5-degree, 7-degree intervals and seeing a rapid progression. If we do, surgery is the right answer because it's only going to get harder to fix. But if they're, if I see them over 10 years and they've progressed 6 degrees over that 10 years, I don't get too worked up about it. And I don't put somebody that otherwise is functioning okay through surgery for that. And curve magnitude, that's a adolescent thing. If you hear 45 or 50 degrees, yes, you operate on scoliosis, that stops at skeletal maturity. That is a teenager thing only. That does not apply for adults. So again, when we talk about the surgery, what do you need to do? What is wrong with the patient? Like, do they have a single level radiculopathy? Like this lady come in, she's 67, left lower extremity pain. It's mostly leg pain, big disc herniation with a foraminal disc. You can see here out into the foramen on what turns out to be the concavity of a fractional curvature. So this is her scoliosis. This is the compensatory, or we call fractional curve. She's got a little bit of a junctional kyphosis, a little sagittal plane imbalance, but she's not compensating at all here. But she's got just left leg pain here. So what do we do for that? I did an MIST lift. I did a single level MIST lift, opened up that, and she did great for several years. I do that when it's radicular pain. I do that when I'm not going to destabilize the main curve and I'm not in the main curve. So if I'm doing this in the midst of the apex of the real deformity, you got to tread pretty lightly. Have I done it on somebody that was a poor candidate for other things? Yes, but like once or twice in my career. Generally trying to avoid operating in the main curvature and trying to stay in that fractional. And it works well if you can stay down below that, and people get some durable benefit from that. So we published a treatment algorithm years ago on how you go through this. It's basically just kind of what I said. It's not worth going through today. So I'm going to show a few cases and workup and things like that. But from here on, we're kind of assuming that, hey, it's not a little single level radiculopathy at L5. It's bigger than that. So we're going to talk about how we look at these deformities. So flexibility matters a ton. A stiff curve will make you struggle. A flexible curve makes you look like a hero in surgery. And right, same surgeon can look real good or real bad depending on how flexible a spine is. So we try and get a sense of what that flexibility is. And that's why we do all these different x-rays. So standing x-rays are the standard. We do an EOS here, which is fantastic. But at least a long cassette film. Supine x-rays tell you, you take gravity away. How does that spine react to that? I either put people supine or prone in the office all the time to try and push and see what they do. Push prone is exactly that. I do that in the office, push them around, see if I can push that and what I can get a sense of flexibility. We don't do a lot of push prone x-rays. We don't do a lot of traction x-rays. Those essentially need somebody to go down, sit in the x-ray and get radiated a little bit. This is a push prone. You can see big lead gloves here. That one of our fellows a long time ago done doing this on a adolescent patient. It's something that you certainly can do. Some people really use that a lot. We don't, just because we don't like our team getting in more radiation than they need to. But CT scan is super helpful. I look at the scouts on a CT all the time, and I will generally do that first before I get into these other films to see how much information I can gather from that. And usually I can get all that I need from a CT scan. If it's a adolescent curvature and I'm trying to not fuse the whole thing, I'm trying to avoid fusing a compensatory curve, I will do supine side bending because I want to see if it bends out to less than 25 degrees, applying an adolescent criteria to it. That's a little bit in the weeds for today, but they're useful. But depending on the institution you end up in, you'll see people that order and swear by all of the above. Like somebody always has their favorite that they like to do for flexibility, but it's important to try and assess it before you get to surgery. This is an example of this. So this is a patient, I don't know if you can see this very well. This is a post-op grade 4 kyphosis and spondylolisthesis. Miserable. There's the zoomed in view. That is an awful patient to treat. This lady was in so much pain. She was just in tears in the office. She had a fusion. It started to pseudo, screws were loosening, so they removed them. That's not the answer. If your screws are loosening, it's because you didn't get fusion. You need to revise that and improve that, not just taking the screws out treats the surgeon so they don't see the screws loosen anymore, but this patient was left miserable. But if you look at the CT scan, look at the reduction just by laying her down. So I knew this was going to be a miserable day until I saw this, and I said, well, once I put her on the table, I can put some screws in there. Right? I realign it like this, and again, you can look like a hero, and it wasn't even that bad, right? I get good enough screws, I can pull along there, eventually even put an inner body in there, and heals great, looks great, and one of my happiest patients I've ever treated, because she went from just miserable because those nerves are just getting traction across there to nearly pain-free pretty quickly after that. Another patient, atypical. This is not a normal person. Somebody that's so flat through there, not standing up, not compensating in a big curvature. This is a connective tissue disorder type of patient. There's just something off with them. They're developing such a deformity. But when you lay her down, look at that. Again, goes with the connective tissue disorder, that it's laxity is her problem. It's collapsing. She can't stand up against gravity. Her spine won't hold her up. But if you lie her down, and if you have her bend, look at how much correction we get through here. So we end up looking pretty good. and that sagittal plane again, because all I need to do is get good fixation in there. Now, this is an old film. This is 12 years old, or this surgery is 12 years old. I've got too much lordosis here. It's not great. The only thing that saved me is I took it all the way up to the top. If I would have stopped this here, she would have junctioned for sure. The fact that we went all the way at the top and she was so hypokyphotic beforehand and we just kind of held it there. Luckily, she held on. So the more flexible the spine, the easier and the better correction. The goals of this surgery is not a straight spine. This x-ray looks great and people like to see it, but it's not straight. It's stable, it's balanced, and somebody that can stand up and function is the goal. This is a functional problem, not a radiographic one. So it doesn't have to be straight, it has to be balanced. Another one here, a more focal curve, equally, I didn't show it on the first one, but you see a lot of this in the adults where they get ribs on hip, right? Their rib cage is on top of their pelvis, and that starts to become painful for them. And it's right, she's got a little kyphosis here. Lay her down, comes up a little bit, but not a lot. So it's much stiffer through there. So I have to be a little more aggressive with some osteotomies through here. And again, if you look at the distance between the rib cage and the pelvis at the end, a significant improvement in that trunk shape. But I had to be a little more aggressive with what I did to get her to come around. This one here, this is an adult idiopathic patient. And you can tell it's a big sweeping curve. It's highly rotated and it's stiff. When we get a CT scan, right, on the benders, this curve doesn't really change at all. You can see she's got osteophytes through here. It's going to be pretty stiff. Those that were with me this week saw the other day we took a guy that had a pretty good osteophyte and thought we could get it to crack and it wouldn't, and had to go down. Actually, I went into the disc and actually popped that open, and then the correction came to us. So sometimes you have to be a little more aggressive, but I accepted a less aggressive correction on her. She stands up nicely balanced. You can see these screws, look where they're sticking out. She's still rotated through there. Her curve is still there. She stands up nice and straight. She's balanced over her pelvis. And that's the goal of surgery, is getting the posture like this, not necessarily the spine straight. This is as good a result as that first one, even though the curve isn't corrected as much. So again, those goals, we want to get people lined up, stable in that standing position. Now, a little more on how we do this, and I don't want to spend tons of time talking about exactly how we do this, but you will hear all the correction techniques, and all of them are things that we use from time to time, and knowing how you use them and what they do is a big part of correcting a deformity. When you apply a force to the spine, what's it going to do? So compression, distraction are something we oftentimes use. Cantilever bending, translation maneuvers, essentially bringing the spine to the rods. Segmental adjustment is kind of doing that at a level by level. We do some in situ rod contouring, kind of as a finishing maneuver for constructs quite often in my operating room. Rod rotation, apical derotation are kind of AIS type of techniques that we'll just touch on briefly. So before we do that, before we apply the fixation, we have to get those anchors. So what do we put in? Screws, hooks, wires, all are something you can do, but you gotta fixate the spine. If we don't have something to hold on to that bone, I can't pull it to where we want it to be. If you look at this patient, this is a complicated deformity. It doesn't look like that big a curve, but it's highly rotated, right? The spine is facing 90 degrees in the wrong direction and almost up against that pelvis. And then these pedicles are like, that's right at that apex. So you can see how rotated that spine is, even when she's supine. Getting something to hold on there to pull that around is really challenging. We'll see if that plays. So sorry for the volume. This is that screw going in that pedicle. Now, that angle, if I walked in the operating room and saw somebody putting in a screw like that, I'd be yelling, stop, 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 you're going through the spinal canal. Right? But it doesn't go through the spinal canal. That's the angle you need to be able to put that in. And you need to be able to put those in at a majority of those levels if you want to fixate that spine and bring it around. And if you can get that, then you can pull that around and get that realigned. But without good anchors to really pull and derotate that around, you simply can't do it. We've had some cool technological improvements, kind of going a little bit old school, where people used to put wires in all the time, which go under the lamina. Some of those sublaminar band technologies that have come out allow you to use a band and not a wire and have tensioning maneuvers. I will use those in certain stubborn scoliotic spines because the lamina is actually quite strong bone, and you can pull that around. If you don't really want to pull in your screws too much, you can use a combination there, and it can be helpful with a translation maneuver. So that's a a nice fallback. Hooks are something that I use oftentimes at the top of constructs, but knowing how to put those in if you're going to do deformity, it's a part of the game, but we try and use screws as much as possible. So if you put a screw in, like what can you do for it? You can retry it. You can try an alternate trajectory. Most oftentimes, if we don't need it, I just leave it out. Putting a hook, wire, cement augmenting are all things you can try and do, because again, you have to have something at a majority of the levels if you really want to reorient the spine. So fixation, which looks hard.
Hey, Tyler, sorry to interrupt. Just can we have quick thoughts from you on concepts around like screw density and where do we need to make sure we get fixation along the construct?
Yep. So for example, the case we just did the other day was a T2 to pelvis, where we're wanting to do correction. I want pretty high screw density, meaning I would like to have 2 screws at essentially a majority of the levels. If I'm doing a translation maneuver, meaning I'm going to pull the spine to the rod, that means I'm going to pull from the concavity of the curve and trying to pull it over to the rod. I want screws at all of those levels if I can. On the convexity, that's more of my holding rod and not so much my correcting rod. I can do without a screw at every level there, but I generally try and fixate most of those levels. Oftentimes for me, if I'm having to fixate long up to the proximal thoracic spine, say because there's a little kyphosis at the thoracolumbar junction, or there's some reason I need to go long, but I'm not really fixing the thoracic spine. As soon as I get through the main curvature, I alternate. I put 1 screw at each level and kind of stepwise my way up. Reducing implant density reduces your cost. It doesn't really impact how much you're holding because you're not trying to correct the spine through those screws, and it improves your surface area for bone effusion. So I do that quite a bit. But I try, again, if I'm using those screws to correct, especially in adults, I want to get as many as I can through those apexes of those curves. Make sense?
Yeah, totally. And I think just it's a place where pediatric scoliotic correction and adult scoliotic correction diverge, right? There's these similarities, but there's a lot of divergence points, and this is one of those divergence points.
Yes. So
that we oftentimes see people applying pediatric principles to adult spines, and it's not enough.
Yes. So the pediatric and adolescent, sometimes they have little tiny pedicles and it's hard for people to get fixation in. That's where kind of the reduced implant density started a little bit. Hooks, they didn't need them everywhere, but those are flexible spines with bones that are strong. So you don't need as much to pull things around. Adult spines are the opposite. The spines are stiffer and the bone is weaker. So you can only pull as much as your screws will hold. And I use the analogy all the time in the office with people with bad bone, or what we're trying to do. I say, if I put a single screw in the drywall and hang a heavy mirror on it, nobody's ever surprised when I got pieces of mirror all over the ground. The same principle applies when we're fixating bone. Like for that mirror, I need multiple fixation points to get that to hold. Same thing with the deformity. If I can pull a little bit on several screws, that's much better than pulling a lot on one. At least, and the worst thing when we're doing a deformity correction, when the screws that we're pulling on start to pull out of the bone, it's game over. Like that's it. I can't do anymore. Like I'm stuck. It is what it is, and it's not great. So we don't want to get to that point.
Thanks. Yep. Thank you.
So just a little bit on those correction techniques. I showed you a little bit of those. We kind of talked through them. It's all about the axis of rotation. Like, again, we're applying a force to the spine and what's it going to do. That little BMW symbol there is it's identifying the instantaneous axis of rotation, meaning if you put a force on a body, it's going to rotate around a point. In the spine, that generally is in the anterior column, but it's, again, called the instantaneous axis because it changes based on how you're applying the force and what kind of implants you have. Basically, when we talk about compression distraction, if we're compressing posteriorly, we're behind the axis of rotation, so we're going to shorten the posterior column, which adds lordosis. If we're distracting posteriorly, we're adding kyphosis. So compression distraction helps you fix scoliosis, yes, but it affects the sagittal plane as well. So knowing that matters quite a bit. Again, just other depictions. This is a 3-dimensional Your spine's a three-dimensional object. Scoliosis is a three-dimensional deformity. So there's a lot of nuance in how it's going to move, and you just need some experience watching and feeling and doing so you get a sense of what that really is. You can study it all you want, but you got to see it and understand how it moves to really, at least I did, to have that really sink in and understand that concept. But this is a kind of old school Lanky 5 anterior approach. People do tethers now anteriorly all the time, so that's kind of new school as well. But when you compress, right, so you put this rod and screws are on the convexity here, they're compressing it, it's taking lordosis out. Now, if it's a TL junction, maybe not such a big deal. If you carry that down here and you start to take lordosis out because you're compressing in the front of the axis of rotation now, starts to be a problem. So you need to pay attention to that as well. This is an example of what we call either Ponte or Smith-Peterson osteotomy. A lot of people call them posterior column osteotomies now, just to get rid of the naming controversies. But if you cut these osteotomies, that doesn't do anything for you. If you cut them and then compress them together posteriorly, you take out kyphosis, like in this example here. So that is, if you hear about a posterior column osteotomy, it is resection of interspinous ligament. So we're cutting between the spinous processes, inferior part of the lamina. I drill inferior part of the lamina out through the facet complex. So inferior facet, the top of the superior facet, and then the ligamento flavum with the kerrison at the end to come out through here. That's how you can do a complete posterior column osteotomy. Again, distraction, compression. Distraction lengthens the spine, compression shortens the spine, and it depends on where that axis of rotation is. Now, we can change that instantaneous axis of rotation into a fixed point by doing something like a pedicle subtraction osteotomy, where if we do carpentry enough to cut a wedge out of that bone, that apex is at a certain point, we create a fulcrum there, we can pick our axis of rotation and use that to our advantage. So that's the whole premise between a 3-column osteotomy is we are creating a big gap here, creating the fulcrum, and then closing that wedge to create that correction. So a PSO is a big operation. People love doing them because they seem like they're cool, but they're bloody. They carry with them a 10% risk of neurologic deficit. And the CSF leak risk is elevated. So they are not without elevated complications. And I always say you do it only if you need it. And for me, that is a fixed deformity. I can't recall the last PSO I did on a still mobile, flexible spine. I've done it on spines that were not previously operated, but they were fixed deformities that wouldn't budge with simple posterior column osteotomies. And again, that you can see that artist depiction of what that is there. So to do a PSO, that is a laminectomy, complete facetectomy, complete pedicle resection. So I can't tell you how many times I see patients come in for revision work that have had a pedicle subtraction osteotomy and they still have all their pedicles. So I don't know what happens there, but they didn't subtract the pedicle, which kind of is right in the name. When you subtract that pedicle, you create one large superframe, and that's going to have 2 nerve roots living in it. That is something to remember. They have to have enough room to both live there. You do that wedge resection of the vertebral body, lateral resection of the vertebral body wall, and then finally, this posterior vertebral body wall that used to be here is like, it looks like it's easy to take all this out, but you got to remember the dura is there. So the nerve roots, the spinal cord, whatever you're working around, they don't like to be stretched. You can't move them around. There's epidural vessels. It's kind of a mess in there. So the very last thing you do when everything else is set and ready is you take down that posterior vertebral body wall, and you usually have to get an instrument in there and push it away from the nerves. When you push it away, those epidural vessels are going to start to bleed, and they're not going to stop until you close that osteotomy. So that's why that is the last maneuver I do. Everything else is done first. Temporary rods are in, everything's ready to go. You take that down and you close it right away. People talk about extended PSO, or what would be called a Schwab grade 4 osteotomy. It's just a PSO that apex is at the disc and you take the disc. It creates a little messier correction because you don't have that nice fulcrum. It's kind of like an opening, and oftentimes you have to put a little cage or some bone graft or something to pivot on in there, but it can be quite helpful. If you have a big mobile disc, it's a pseudoarthrosis point. So taking that out can be advantageous in that regard as well. Essentially, vertebral column resection is taking out the whole vertebral body. People use VCR and corpectomy interchangeably. That's inaccurate. if you do a corpectomy or vertebrectomy or spondylectomy, those are tumor and trauma operations where essentially you are trying to remove that segment and reconstruct it as is, if that makes sense, right? You're trying to that's where people use expandable cages and things to fill that space back up. If you're using an expandable cage in a VCR, you got to think twice. Like maybe you're not doing it like a real VCR. You don't want to lengthen anterior column, right? That stretches spinal cords. If you're trying to correct deformity, this is a shortening operation. So a VCR is essentially, I'm removing that same segment, but I'm going to put it back together different than it started, not trying to reconstruct that same problem, because in this scenario, the problem's a deformity, and we're trying to correct kyphosis usually, or a severe fixed scoliosis. So essentially you take that entire vertebral body, you have to take the ribs that connect there as well. We oftentimes use those ribs and save them for bone graft afterwards. And every now and again, you can close that bone on bone, but usually I close it halfway. I put a small cage up or bone graft up in the front, then I close down the posterior. So I'm trying to leave a little bit of something in the anterior column so it closes less than the posterior column does. The reason for that is if you compress it all the way straight down, you're getting a lot of shortening of the spinal canal. So you risk spinal cord or blood vessel kinking and neurologic issues. So we try and maintain some of that anterior column height and get that posterior column height so everything just shifts a little forward as opposed to just accordioning down. Does that make sense to everybody? I'll take that as yes. Essentially, it is that. So it is removing a segment of a kyphotic spine. But if this was a tumor, you put an expandable cage and fill that in, put your rods in there, and you're done. We're trying to make that kyphotic spine less kyphotic. We're not really trying to make it lordotic, right? We're trying to make it less kyphotic. And putting something in there, usually I kind of want to do 50% of the height of the original defect and close it down so that holds that up in the front, gives you some anterior column support, but allows that to close and pivot across there and correct that deformity. So translation maneuvers, that's one of my go-to in terms of that. So this is shifting. This is not a 3-column osteotomy anymore. I'm back to using the patient's own axis of rotation. This is that patient I showed in the beginning, put a bunch of screws in there. And how am I going to get this spine to this? I'm going to put this rod in here, and I'm going to pull those screws over. And I call it a translation derotation maneuver because usually the rod doesn't just sit lateral. It sits like posterior and lateral. So the spine's going to come up and over to that as we reduce those. Oftentimes we use those tower reducers or reduction screws along that apex to do that. But if you have good fixation and a mobile spine, it works great, especially for adult deformity. It is my first correction maneuver in most adult degenerative scoliosis cases. Again, and that's just pulling. You have a rod that's where you want it to be, and you're going to pull that to that rod. Whether this is kind of old diagram of what that was, it shows kind of the translation derotation a little bit, where this is with the wires, where you put the wires around, you twist the wires down, and it does that same thing. Now we do that with the screw technique. But as that comes over, it just is kind of nice. You can see it's rotating around, if you can tell what that spine is doing, getting straighter and derotating a little bit. How much time do we have? Oh.
You're good.
Yeah, it's just they're kind of boring videos, but
videos are always good, man. I've never seen a video I don't like.
No, I don't know. Like they just take too long. So this is an old technique again. So this is a thoracic scoliosis. You can see we're going to clip a few of these reducers on. I've got the rod fixated at the bottom down here, locked in some screws. This rod holder is kind of holding it in some of these, in the top screws. These screws are up here. It's lined up in those screws. And these screws don't meet up to that rod, which is kind of straight in that coronal plane. So generally, I'm going to fixate over at least 3, oftentimes 4 segments across that apex. And again, just setting these on here, getting them positioned. And then I will go and sequentially turn them down each a little bit at a time. So just getting things out of the way, but I want them holding that so it stays in that. And I'm kind of assessing stiffness. And kind of the key, which makes it a translation derotation. If you can see my hand is kind of pushing them up a little bit. As I derotate, I'm going to try and lift those up, or as I reduce, I'm going to try and lift those up a little bit. So as the spine comes over, it's also going to come up a little bit. That's a polyaxial screw, right? And it's going to kind of do this maneuver. If you use a fixed angle screw, you can, or a monoaxial, meaning it goes sagittally but doesn't go coronally, you can be even more powerful with that. But for most adult surgeries, I don't find that to be necessary. If you're doing an adolescent scoliosis where you're really trying to derotate a big rib hump, it's much more effective if you use a screw that doesn't move in the coronal plane. So, right, so you can see I kind of lifted those up as we go, and then we lock things down and do one more move. So this was a spine that we released several segments that kind of moved around, and that's that. So after everything's done, if I don't like what I have, I do a little in situ contouring. I try not to in situ contour too much because every time you bend a rod, you're adding a little bit of what we call notching. So you're putting little kind of micro bends or little weak spots in that rod and increase your risk of rod fracture potentially over time. So if you have a scoliosis and you find yourself bending the rod finally to get it where you want, as much as you're going to hate to do it, the right answer is lock the other rod down, take that one back out, start with a whole new one and put it back in so you don't have to bend it so much to get to that position. You don't want a weak rod. Oftentimes now, the rod that I work the most to get things corrected, I will put a third or fourth rod in adult deformities in the lumbar spine, usually a third, but I'll try and put that third rod on the side that I work the rod a little bit more to try and help buffer that a little bit. Again, so this is kind of an in situ contouring. So I loosen the rods and I'm just going to give a little squeeze. This is coronally correcting that same deformity, just a little squeeze, not a lot. Just I'm going to go segment by segment by segment over and over, just a little tiny bend. And I was working one rod and I'm coming back to the other side, trying to just pull that over a little bit more until we get that fairly straightened out. But you can see like none of those are big bends. There's not a lot of force. I'm not cranking on any segment at all. I'm just tweaking it a little bit. And like, I don't love how many times we do this. You can do compression distraction many, many times and you're not weakening your rod. That's a good technique in this scenario, but a little bit of that correction. But again, it's a little hard to tell. You can see that rod is pretty straight though. Like that spine is pretty straight and it was a pretty big curve to start with. So that combination of techniques works pretty well. So cantilever, when people talk about a cantilever force, essentially it's the mechanics is a cantilever beam, which is a beam that's fixed at one end. You're going to push that down. And in the spine, when we have screws here, when you push that down, we're going to push the spine with it. And if you bend lordosis into your rod, say at the bottom, fixate your sacrum and pelvis and bend it down, you kind of push that spine into lordosis when you do that. Let's get that a little bit. Rod rotation. This is a old scoliosis technique. Don't use it very often in adults, but just so you know, so you know the jargon that people talk about. It's putting in a rod, right? This is a three-dimensional deformity. If you think about scoliosis, in the thoracic spine, what should be kyphosis has become scoliosis. So you put a rod in crooked and you rotate that scoliotic rod to a kyphotic rod with screws that are attached to the rod, but not tightened down. So they're loose. So it'll come around with that. That was done with hooks originally. That was the original Cottrell-Dubuisset type maneuver. And that has advanced to something called apical derotation. This is a very powerful tool. You build this crazy construct. If you see apical derotation sets, never go into a surgery with an apical derotator that you haven't played with outside of the OR. They're a mess. They're a fiddly mess of things that connect, because you're trying to essentially link a bunch of screws together to grab the spine as one big block and rotate it in a certain way. It's really meant to derotate a rib deformity. So when you have a big rib hump on adolescence, which is a cosmetic thing, you want to push that down and pull that up on the other side. And you want to do that over multiple screws and not just one. It's tricky though, because if you just push that at one segment, you're kind of corkscrewing the spine. It's not going to be good. You need to counter derotate at the bottom down here. So it's not just putting one big twist into the spine. You're trying to derotate it against each other. So one goes one way, one goes the other way. And that's how you end up with a straighter spine in a deformity that's corrected. Again, something to fiddle with in cadaver labs, on the back table, learning how those things work, and watching them utilized before you ever just go and try and use them, because there's some real nuances there. It's on your pediatric rotations. If you're seeing that used, pay attention, because it's interesting to see, and it's helpful to understand how that works. So bringing it home, when I see a deformity patient, we assess the deformity, see what's going on, figure out, do we think there's a surgical correction for this? And if so, can this person really handle it? That is the big question. Are they medically appropriate? Are they socially appropriate? You can't take an 80-year-old that lives on their own and put them through a big scoliosis operation and expect it to go very well. It's going to be rough. I just did that to somebody who's wasn't 80, he was like 73, but lived on his own, not great social support, but he had a chin on chest deformity and couldn't eat or swallow anymore. So it was going to go pretty bad, but it's a rough go in terms of the post-operative care. Like, so you really need to look at that and figure out everything you can to see if they can do that. Is their bone good enough? You can make a beautiful x-ray on the table, and if they stand up and all falls apart, nobody's going to call you a hero. Do they get the motion restriction that comes from this, which is a big part of the conversations I have with people? And do they really understand the risks of what we're talking about? Scoliosis surgery has gotten better and better and better. Like, what we do today versus what we did 10 or 15 years ago is markedly better. Our complication rates are down, blood loss is down, length of surgery is down, length of stay is down, ICU time is down. That's all great, but it's still a big deal. Level selection, right? Where do you need to go? That's sort of outside the scope of what we talked about today. Preventing PJK, important, but again, outside the scope of what we've sort of talked about today, but all things that I think about every time I'm talking about a deformity. And then when do we say no? A lot. If you can't do the right thing, try not to do anything. So somebody might want surgery and they're just not appropriate for the right surgery. Trying to do something small and get away with it is a high risk maneuver, because you start them on a path that now they really need the operation that they couldn't have in the first place. And it's a hard place to be. If the medical risk is just too great, it is what it is. And if the patient just can't handle it, like, you can have, again, a great looking x-ray and an unhappy patient and nobody's happy. I think that's all. Again, whirlwind tour. So I know it's a lot that we covered there. I wanted you to sort of see some things and hear a lot of the buzzwords, so things to think about. And hopefully that gives you a framework to at least think about things as you see them as you go through training.
Tyler, thanks for doing that. Super helpful. I think I'm kind of left with, as always, new things I learned, and then things that have been reinforced, and gosh, probably more questions than answers, right?
Yeah.
I think from a residents and fellow standpoint, would you agree, or tell me if you disagree, the take home points that oftentimes will end up being on boards and on in training are going to be around understanding sagittal parameters, understanding the link between sagittal parameters, including pelvic incidence in that. Think about pelvic morphology, understanding a little bit about corrective techniques to some degree, not in depth, but at least understanding what options we have for fixed versus flexible curves. And when we do our cervical deformity talk in a few weeks, that same concept's going to kind of come up again. And then those are probably the testable things, but the actual clinically applicable things, we're all going to see, as you mentioned, we're all going to see scoliosis patients in our practice, right? And so helping them understand what it means to have a curvature, what it means to have a scoliosis. Sometimes it's normal, sometimes it's abnormal, and giving them some context is super helpful, because I think all too often we see a lot of things attributed to a scoliosis, right? Or that really aren't the case. The last thing that maybe we can spend a couple minutes on before we leave, there's a burgeoning interest in the orthopedic world about the interplay between scoliosis and hip replacements, specifically around the link, with regards to the impact on post-operative, hip surgery, let's say, or when to do a hip versus when to do a back. So I know it's a it's a vague question, but maybe your general thoughts on how we give some insights to our hip and knee partners about what to think about when it comes to the back.
Yeah, it's super common in my world. People that develop significant degenerative spinal disease also develop hip and knee degenerative disease as well, and how that all comes into play. Every now and again, you see something really interesting where somebody has a spinal deformity, such as a flat back deformity, something that they're having to really retrovert their pelvis, and they start popping out their hip joints. Like they do a hip replacement, and I have one right now where I saw the patient, she keeps dislocating her hip anteriorly, and it's really because they didn't do that. I sent her over to over to Manning to take a look. It's her hip replacement wasn't done correctly because her spine isn't all that bad, but there's definitely an interplay. My biggest concern with joint replacement is always, what is it going to do to limb length, right? Is it going to keep it equal? Somebody that has a pelvic obliquity to begin with, or a leg length discrepancy, if I go and correct their spine, I generally, if they've got an actual leg length discrepancy, I will correct their spine crooked off the pelvis. I will measure what that angle is and try and get them to be off the pelvis, so their spine can, or their pelvis can be a little tilted, and they'll still stand up straight. If they go and then have a joint replacement that alters that, now they're tilted off, and it can be problematic. So in those scenarios, if they're equally bothered, I like to have the joints done first, so I can see where that pelvis really sits at the end. And I think patients from a spine surgery will rehab that much better if they can walk, right? They need to ambulate after that. But it's a common thing in my world, like, what should we do? Which one should we do first? And if one really bothers them more, if somebody has such severe claudication that they're miserable and can't walk, we'll do the back first. But it's a tricky scenario. But yes, there is a lot of talk about, like, if the spine is really rotated around, how does it affect the pelvis? How does it affect that? And we know those impact each other. How big a correlate that is, and my always thought is, when people ask me the question, like, well, what part of it is fixable? Some people have like an internal pelvic obliquity where it's just a little misshapen there, and I can fix their spine. It's not going to change that at all. Some people just stand funny, like, right? I can make their spine look really straight, and they're still going to lean on that one hip more than the other for whatever reason that must be beyond my comprehension. But some people just don't do what you think they should do if you do all the math on their numbers on their spinal alignment. But it kind of is. But that is something that's a question that comes up all the time. It is super common, and you need really good partners in the joint world that have a good discussion with you. And so we're lucky here on that.
Yeah, for sure. Great. Thanks again, Tyler. Any other questions, comments from the group that's on tonight?
I think Tyler, you hit it nail on this head when, like, especially for our residents who get a good exposure to pediatric deformity correction, the bone is so different and it's a flexible spine. I think adult spinal deformity is, like you said, the opposite. And, what I've always struggled with is, like, understanding how to achieve a correction of the stiff spine. So I think you gave a great overview. I think there's multiple factors to consider, especially like when you need to, like, release, like the disc and the anterior column, things like that. So
all kinds of ways to do it. I sort of talked a little bit about moving things around, but anterior inner bodies, whether it's on T-lift, A-lift, lateral, there's a myriad of ways to go about doing these things that, right. And it's not one size fits all, right? It definitely, the right operation for the right patient is the key to success in this world.
Yeah. For the residents, I think it's just show, like, there's multiple different ways to approach it. So keep you guys, I guess, just keep an open perspective to everything you see.
Yeah. I mean, the key is to figure out what the problem is and what you can do best to correct it. Because no matter how you do it, you want to end up in the same thing, with a stable, balanced spine, so the patient can stand up and walk without nerve pain and things like that. And if there's one way in your hands that accomplishes that goal more reliably, that's a perfectly reasonable thing to consider. And that's why it's good to get a broad exposure to all the different techniques.
Great, thanks.
Yeah, thank you all. Have a good
all right. Anybody else, feel free to chime in. Like I said, we're pretty laid back, but at the same point, we're hitting the top of or bottom of the hour, so we're at our time. Tyler, thanks for taking the time to give us your thoughts, and really do appreciate it, as always. I constantly learn a ton from you. So all right, and everybody be well. We've got another lecture in a couple of weeks, and we'll make sure emails are sent out. Hopefully this 5:30 time slot works a little bit better for everyone than the 4:30. And spread the word. Feel free to share the links. Feel free to share the connections to anybody who might want to join. All right, take care now.
Thanks so much.
Hey, Dr. Koski, I actually did have one question for you. I really appreciate the lecture. For your preoperative counseling for your adult spinal deformity patients, we know like tobacco use, smoking, increased pseudoarthrosis, perioperative complications. But for you, do you view that the nicotine replacement options kind of have like similar effects to patients? And is that okay for your patients if they're really bad off, or do you have them?
I don't let them do any nicotine. Nope. I'm a stickler about all of those things. Like all those parameters we have, I make people pass a urine nicotine test to get scheduled. So if somebody's a big time smoker, I make them be off enough to pass like a urine continine, which, takes a few weeks to clear the system, to get scheduled, which then takes, 2 months to get on my calendar to do that. And then we test them again at the end. Now, if there's some urgency to something and, I want people to quit smoking first, because has some pulmonary complications with an anesthesia and things like that. And they can use some nicotine replacement. But after surgery, right, it's got to kind of be a cold turkey. The problem with that is anytime you ask a person to do that, like, oh, yeah, I can do that, they can never do that, right? 100% failure rate on the people that tell you, oh, I'm not going to smoke afterwards. They're always going to smoke afterwards. So I make them pass the test, really be nicotine free, unless, again, there's extenuating circumstance or some urgency to it, but I do it every time.
Okay, awesome. Thank you.
Yeah. Cool. All right. Thank you all.
All right, thanks.
Have a good evening.